Labdien, cienījamie klātesošie, labdien visi, kas vēro mūsu semināru Zoom platformā. Šodien mums ļoti svarīgs notikums. Veselības aprūpes jomā jau otrais šāds seminārs par neirostimulāciju, dažādiem neiromodulācijas veidiem. Šoreiz viņš ir starptautisks, mums ir viesi no Lietuvas un citām zemēm. Un ņemot vērā, ka pašreizējā laika neirostimulācija un tehnoloģijas, kas tiek iegūtas vēl ar vien tālāk, atļauj mums virzīties šajā jomā. Ārkārtīgi svarīgi, lai Latvija pārņemtu šīs tehnoloģijas, iekārtas un arī iespējas tās pārvaldīt. Tātad mums ir starptautisks seminārs, ciemiņi runās angliski. Šis nav publisks pasākums, tas ir speciāls pasākums, seminārs šauram skatītāju lokam. Tāpēc mēs pāriesim uz angļu valodu, lai viss notiktu raitāk un visiem būtu viss saprotams. Dear participants of the seminar, you are welcome in the headquarters of Latvian Physician Society, where we traditionally try to organize our seminars, and this neuromodulation seminar is especially important now. The new technologies are emerging even faster than previously in all spheres of medicine, and especially neurology and neurosurgery. Latvian Society of Neurodegenerative Diseases, led by Professor Karelis, kindly allowed us to work under the auspices of this society. I'm informed that Professor Karelis is following us on Zoom platform. Professor, great thanks for your assistance and possibility to work in the framework of your association. I think this will be good promotion also for your clinical hospital and for your neurological division of Strategic University. Now we have very important several reporters, with unique technologies and techniques, already with good experience in usage and first results, they will be clear. And first is Dr. Andrius Radžiūnas, neurosurgeon, head of functional neurosurgery sector, neurosurgery clinic, Kauno Klinikos, Hospital of Lithuanian University of Health Sciences. And this topic is deep brain stimulation for Parkinson's disease, patient selection, operation technique, post-operative management. Dr. Radžiūnas, floor is yours. Please come to the laptop and handle maybe yourself the presentation, please.
Okay. Hello for everyone. Thank you for the opportunity to present my experience and some maybe notes regarding surgical Parkinson's disease treatment. Today I will present deep brain stimulation of Parkinson's disease. From the beginning, doctors or societies try to treat ill patients with different techniques. Some are horrible and historical, but still remains in our memories. Moreover, some patients as psychiatric patients and some movement disorder patients were treated also with the horrible techniques. And anyway, we still searching for the best approach to alleviate their illnesses. All of you know all these four important persons. They share the same disease, Parkinson's disease. Of course, none of them got the DBS, but all of them were very supportive in the development of DBS. This slide I have put it intentionally just to show a historical moment in the history of Parkinson's disease surgery. You see here that there is some curve of pielietojums. It's a stereotactical functional operation. You, with the radar frequency, stereotactically you ablating globus pallidus internus and alleviating some Parkinsonian symptoms. As you see here in that hospital, suddenly there was a sudden drop of the operations. It started in 1968, and you can ask what the reason was. Yeah, so actually there is very simple explanation for that. It's L-DOPA therapy came at that moment, and everyone thought that Parkinsonian patients have a cure. Yeah, but they was wrong. Yeah, you see that after the 5 years, there is again sudden rise of operations. So it means that after honeymoon, doctors noted that the L-DOPA therapy induced some negative effects, and again, you cannot avoid surgical treatment. Yeah. So also doctors were all the time was thinking how they can help for those patients, and not in a very, how to say, invasive way. So the electrical therapy was also started to use, and there are a lot of experiments during the history of electrotherapy, but in SSSR, Natalia Bektereva published first experimental observation of chronic electrostimulation in the deep brain structures, and according to that foundation, modern deep brain stimulation became available. So Louis Benabit, who was pioneer at that moment, he was working in the Grenoble, started first DBS decade. After the decade, he introduced the most, how to say, promising target in the brain for stimulation is the subthalamic nucleus. And from the 1990s, we have very successful target for the Parkinsonian symptoms alleviation. So doctors still are using subthalamic nucleus as the gold standard for Parkinsonian patients. So, but this is just the beginning, yeah, of the way, because neuromodulation itself has different parts. So it means that you have to have target, you have to have proper patient, you also have good technologies to work on that. Yeah, so the neuromodulation itself, it's just a very small part of that view. Yeah, it means that right now there are a lot of research in this area. So it means that there are some hypotheses why it works for Parkinsonian patients, why it doesn't work for example, for Parkinsonism patients. Yeah, so it a lot of experiments and experimental models were carried out, but right now we know that electric current affects some circuits in the basal ganglia, and it affects also some neural tissue around that, and also it changes some neurotransmitters, and it changes the course of Parkinson's disease. Anyway, subthalamic nuclear stimulation for good selected patients will bring reduction of tremor, reduction of rigidity, and bradykinesia. From this slide, you see that that small nucleus, which is just a 2 millimeters wide and 4 millimeters length, has just 3 parts. Yeah, so it's just a sensomotor, associate, and limbic part. So it means that if you put electrode in the wrong part of subthalamic nucleus, you will get different results. So you can, if you implant in the limbic part electrode, DBS electrode, you will induce hypomania for that patient. Yeah, so it means the strategy and the surgical technique is very crucial for these patients. Yeah, so and as I mentioned before already, patient selection is the key for the success. Yeah, so you have to have a very strong team which are working together and helping just to select the best candidates to achieve the best results for those patients. So the main the main role is played by a neurologist who is offering for the patients this surgical treatment, doing some tests, as you see here. We're doing L-DOPA challenge test, checking those patients with the different clinical assessment tools. Also, a neuropsychologist is a very important person in our team. He's doing some neuropsychological tests because if for example we in Lithuania at the beginning we didn't have neuropsychologist. Yeah, so we just selected patients just on the clinical view. So we had even some psychiatric side effects, but with the neuropsychologist we started to develop a better approach for our patients, and our results are getting better and better. So, and you see here, neurosurgeon is as a man of work. Yeah, he's doing that surgical work. Yeah. So indications for Parkinson's disease, DBS, as you see here. Patient must have idiopathic Parkinson's disease, so it means it doesn't have a Parkinson-Bliss syndrome. So it means that he's already has PD motor symptoms at least 4 years. The patient has a good response to L-DOPA. So this part is, I think, it's most crucial, because it shows how well he will respond to that electrical stimulation. Yeah, and of course motor fluctuations and fluctuations of drug action. Yeah. So L-DOPA challenge test is one of the tests which shows how good response will be to our stimulation. Usually we do it in an outpatient manner. Neurologist suggests for the patient just to stop his L-DOPA therapy for 12 or even 24 hours, and at the morning they will usually give 1.5 higher L-DOPA dosage than usual, and he expects UPDRS improvement for more than 30%. Of course, we have contraindications. Usually, this is psychological, and we have if it's advanced Parkinson's disease, so it means that the patient has a dementia already. So an MMSE score is lower than 25, so you have to be careful because after the STM stimulation or even just a simple surgery, you can hurt patient. Yeah, so it means that you can lower some MMSE points. It means that after the surgery, that patient will have a good movements, but doesn't have good social life. So you have to be careful on that. Yeah. So, of course, it's at the end I wrote social state. You see here that is also important part. It doesn't mean that the patient has to be rich or something like that. No, it's not the case. Social state, it means that that patient have to have good relations with her social environment, because he have to come for checkups, just for programming, also for IPG replacement, and so on. So you have to be careful on that as well. Of course, you don't have to forget other surgical interventions for Parkinson's disease, because those patients who are contraindicated for DBS, they might benefit from other therapies, surgical interventions such as pallidotomy, stylotomy, or radiosurgery. So you have to consider that and discuss with the patient. Again, I'm talking about a team. Yeah. So I'm 100% sure that without the team, you cannot get the great results, because the team is what we expect. The team is the key, actually. So if you have a good neurologist, so you as a neurosurgeon you can be very, how to say, successful surgeon, because if they select good patients, so it means that your practice is just a simple part. Yeah, so you have to put the electrodes just in the spot, and you will expect that you will get results what everyone is expecting. Yeah, so this is the key. Okay, so going to technique. DBS, deep brain stimulation, has different stages. First stage is frame placement. Yeah, there are different stereotactical frames. In Clinicos we use Laxel frames. Right now we have two different frames. So it's the Laxel G frame and the newest model Vantage frame. The proper placement of the frame is very crucial, because without that, without the proper placement, so you won't get ideal MRI images, or tactical MRI images. So it is very important to perform tactical MRI in the proper machine as well, because if it has a lot of distortions and stereotactical images are not so well done, it means you have to correct some coordinates, and during that surgery you have to be careful not to injure some important structures because of error, which can be due to incorrect MRI. Yeah, so third stage is micro-recording. Micro-recording is it depends from the center. Yeah, so 12 years ago, when we started DBS practice in Clinicos, we have started with a micro-recording. So it means that you visualize neurophysiologically the target. So it means that you introduce some microelectrodes in the STN area. You record micropotentials around that area, and you know that you hit the STN. And after some after some stimulations, you expect that you are in the correct target. Right now, we just started to use lead placement without a mirror, and our results are actually getting better, because we know radiologically that we are right in the spot, and after the implantation we are right in the STN. So if you are not in the STN, so you wouldn't expect that you will get proper results. Yeah. So this is one of our patients with the essential tremor or Parkinson disease. Yeah, you see here that his right hand is very disabled, and he cannot perform even some simple tasks. You see here we had an awake surgery with the macro stimulation, and after the stimulation started, we see that his hand stops. So it means that we are right in the ventralis intermedius nucleus, and here we see the second video where the same patient is with the stimulation on, IPG is on, just 1 day before, 1 day after the implantation. So you see that his movements is smooth and fast. Yeah. So this is another video from one of our patients that I did a few weeks ago with the vantage frame. So the technique is simple. So we are putting the vantage frame, preparing boreholes surgically, insertion of stereotactic cannula right into the target, and through that cannula we are putting DBS electrode. Just after the replacement of the electrode, we are going right away to the another side, also connecting IPG pocket with the extension leads. And for example, right now we are doing it takes about an hour and a half just skin to skin all the procedure. And if you would compare when we have started 12 years ago, that was about 8 hours. So you see how the technique was changed. Yeah. So in another video we see another kind of frame. So as I said, the Lexel G frame. So with that frame we are doing the same job, but also you can do implantation just checking implants just in the right in OR with our intraoperative CT, and it's you can make a surgery even faster. So the technique of the implantation is pretty the same. And as you see here, the lead placement is all the time is checked during the surgery. So going a little bit faster, here we see that you can play with the neurostimulation programming, and you can, with the different settings, you can just achieve a different stimulation areas, and you can, if you have multidirectional leads, you can just stimulate some parts of STN and avoiding all other important structures, as for example in this example internal capsule. Yeah. So here is, you see that also one of our patients with the Parkinson disease is this is as you see here in the left corner the patient, how it looks just before stimulation is on, and on the right corner you see that how it looks his movements just after stimulation is on. Yeah, so you see his rigidity and bradykinesia is very different. Yes, you see it's very obvious. Yeah, so okay, and I also want just to show that some examples of DBS and for dystonia patients, because I know that Latvia wants to start neuromodulation and for all kind of illnesses. So it's, you see here, this is a boy with a severe dystonia, with a very painful dystonia. He couldn't walk, he couldn't perform his even schoolwork, and as you see here, just one day after operation and after turning on the IPG, how it looks. And this is the second video, is how it looks after 1 month. Right now it's 5 years past after the operation, and he looks even better. So thank you very much for listening to me, and yeah, thank you.
Thank you, Dr. Radžiūnas. Dr. Radžiūnas has to leave soon due to the timetable of his transportation back to Kaunas. So that's why maybe now, if you have some fast, short questions, please ask now. Yes, Dr.
It's also possible to implant using a frameless system.
Yeah, of course. Yeah, there's different techniques what you can use. Yeah.
Thank you. Any other?
If I could ask a question.
Yes, please.
When you use extension leads in your cases, are they MRI conditional?
Yes, all they are all.
Including
Yes, of course. Yeah, you can perform even free tests for MRIs.
Okay.
Thank you. No questions for the moment, so thank you.
Thank you very much.
Dear colleagues, our next presentation will be done by Dr. Rokas Tamašauskas, consultant in pain medicine and anesthesia, pain services in Cambridge University, hospitals, Foundation Trust, and the title of presentation is Setting Up a Successful Spinal Cord Stimulation Service.
Thank you very much, dear Chairman. Thank you for... is it projecting all right? Okay, thank you. Thanks very much, first of all, for inviting me to Riga. Always nice to visit this lovely city again. I work in Cambridge. I've been working at Cambridge University Hospital for 18 years. I lead the pain service there. I'm an anesthesiologist by trade. I finished my anesthesia training in Lithuania many years ago. I did my pain fellowship at University of Chicago, and then worked a few years back home before moving to Cambridge. And it's been home for me now for the last 18 years. So 9 years ago, we set up a spinal cord stimulation service in our hospital, and I thought it would be quite useful, perhaps, for me to reflect and share some our journey and what we've learned over that 9-year period. So I understand that there is a lot of enthusiasm in Baltic states and Latvia to enhance neuromodulation services, so that might actually be quite handy for someone of you who would be thinking along those lines. So successful service, it depends how you define success, isn't it? So first of all, we think about patients. Your patients have to be happy. They want good outcomes. They want reliable access to the service. They want good support throughout the pathway, and that's that's very important to factor in. The team has to be happy. As Dr. Radžiūnas mentioned in his talk, the team is the key for success, and I will wholeheartedly agree. The easiest bit is to implant. The most difficult bit is to select the patients and then make that implant work long term. So a team has to be happy, and they have to be involved in the decision making. They have to be able to have some autonomy. We rely on SCS nurses a lot. They program our patients. They have their own clinics. They feel part of the service, and rightly so. And they of course have to be well supported with training opportunities. Your referrers have to be happy. Normally, when they refer to spinal cord service, they don't want to hear about this patient ever again. So we try to keep them sweet and nice. And well, that's a bit of a joke, of course, but generally, you want to be providing good results for your referrer. The hospital has to be happy. And all the hospital is interested in, as we all know, is to income, tariffs, and theatre utilization. So that has to count. And the organization of your service has to meet those criteria. And of course, when all these, the funders have to be happy, the ones who pay money, and all they're interested in cost effectiveness, is the money, public money usually, that is, are well spent. Is there good return on investment, as it were? So the cost effectiveness analysis for your treatments have to be well within the limits. And that depends on your complication rate, it depends on your success rates. And of course, when all these points have been ticked, you have to be happy. And that, of course, we have all ourselves, an individual model of our perfect happiness. So I didn't put anything into my slide from the personal happiness point of view, but you have to be happy. So, of course, this very schematic drawing of a spinal cord stimulator. It started in 1966, so more than 50 years ago, when Dr. Sheely used the monopolar electrode intrathecally to palliate the pain from lung cancer in a patient. And the patient was pain-free for 1.5 days and then died peacefully. So that is the start of the spinal cord stimulation. So 50-something years on, of course, it has made a huge progress. However, the technology, if you look at it, is essentially the same as was half a century ago. There are leads, electrodes at the top of the leads, and an IPG, which drives the electrical signals. So the various, of course, designs available, mainly cylindrical and paddle, depending on how you want to place them. In UK, absolute majority of the leads are cylindrical, placed through the modified epidural needles. Technology has advanced particularly over the last 20 years in such a way that leads break very infrequently these days. They migrate very infrequently because of the better anchoring systems. And IPGs, they can provide stimulation for up to 10 years according to the newest rechargeable mathematical modeling across various companies. So it's all looking good from that perspective. The mechanisms of action, I think the difference from Dr. Rajunas' presentation is that Dr. Rajunas has the target. The pain hasn't got a well-defined target. So how does the spinal cord stimulation work? The spinal cord stimulation is the electrical field that penetrates through the dura, through the CSF, into the dorsal columns and into the dorsal horn. And by shaping your electrical field, one can recruit nerve fibers that would enhance pain inhibition, and it can suppress or hyperpolarize fibers that can enhance pain transmission. So by carefully selecting what to enhance and what to suppress, spinal electrical field can achieve a reasonable suppression of wide dynamic range neurons in the dorsal horn. That's essentially, at least that's what's believed is the main target of neuropathic pain. So this is how it looks. On the left, it's the patient implanted with 2 octapolar cylindrical leads from AP and lateral view, posterior epidural space. Placement usually lower for the lower extremity pain is lower thoracic, T8, T9, T10. Close to midline, bilateral. These days we usually put 2 leads, even though the pain is unilateral, and I will talk about a little bit later why. On the right you see the cadaver dissection of how it looks in a cadaver. This slide tells you about how often spinal cord stimulations implanted in UK. This is across all the country, and you can see that per 100,000 population, several big centers implant up to 15. Majority of centers are around 5 to 10, and quite a few centers in the back which implant less than 5. So you have to remind me, how many million is the Latvian population?
Less than 2 million.
Okay, so according to UK implant rate, that would be probably around, if say you are a moderate size center implanting, you know, 5 per 100,000, that's probably going up to 100 a year. That would be kind of UK, UK numbers. So on the right side, the next slide talks, just the one slide to show how is it cost effective? Because the spinal cord stimulators, they cost a lot of money, and obviously the hospitals, the funding, organizations, they have concerns about this kind of high upfront cost. So the cost effectiveness analysis was the mainstay of NICE guidance in 2008, and essentially, in order to gain quality life years, you have to invest something. But that investment has to be reasonable, because at a certain point, the more you invest, the less you gain, as pretty much everything else in life. So for in UK, that threshold of an investment is £20,000 per quality of life gained. It's called ISO. The number itself, it doesn't mean much, but if you are approaching 20,000 of ISO of 20,000, you're likely to be not very cost effective, and you may not get funded for that. So the spinal cord stimulation from 14 years ago now, we're able to show that the cost effectiveness is well below 10,000. ISO is between 3 to 9,000 per quality of life year gained. So that's, I won't go into the detail of health economics here, but it's just to show that over the years, in well-selected patients, in well-managed spinal cord stimulation clinics, you can achieve a lot of savings through medications and other healthcare utility usage by implanting these devices. So when will SCS work well? It's when you will select the patient well. And the dominant mechanism, the key, and I believe this, the key, it has to be peripheral neuropathic pain mechanism. So for post-stroke pain, for spinal cord injury pain, for full brachial plexus avulsion pain, MS, fibromyalgia, these are not good indications for spinal cord stimulation. You're likely to have a failure sooner or later, probably sooner rather than later. Radicular pain, peripheral neuropathies, including diabetic neuropathy, but not small fiber idiopathic neuropathy, post-mastectomies, post-thoracotomies, post-incisional herniorrhaphy pains are good targets for SCS. Axial neck and back pain, only if neuropathic component is comprising a significant part of that. And that's the hornet's nest or can of worms, if you will, because in low back pain, it's always very difficult to know the proportion, how much of pain is mechanical, how much of pain is neuropathic, how much of pain is muscular. And I think that's where the team and selection and experience comes into a fore. And angina, good indication, but not reimbursed in UK because of the not enough cost effectiveness, not enough saving. Patients die sooner with this intractable angina when implanted, therefore there is no return on investment. Very, very cruel, but very simple economics. Peripheral vascular disease and ischemic leg pain, good response, but again, not cost effective, not recommended, not reimbursed. Occipital nerve stimulation, sacral nerve stimulation, this is outside of the scope of this presentation. I have very little experience with that. So this is a typical good candidate who I incidentally met yesterday in my clinic. She's Jackie. She works in our hospital. She's 58 years old, female, with right radicular leg pain and numbness, very nicely following the mainly L5 dermatome. Right buttock pain and minimal low back pain. No symptoms on the left side. History of radicular pain on the right side for 3 years. Disc prolapse, nerve root compression. In 19, she's had right L4-5 laminotomy with discectomy, with good effect initially. 3 months later, during the physiotherapy session, pain returned, never subsided, and she's gone through the mill. She's had antineuropathics, she's had weak opiates, she's had more physiotherapy, she's had L5 nerve root block, she's had transforaminal epidurals, she's had facets, SI joints, nothing really helped. She is otherwise very determined and very stoical woman who works still in the maternity unit. She manages the operating theatres during the night time, 12-hour shifts, always on her feet. She's towards the end of the shift, she's exhausted, she's very, very tired, she's in a lot of pain. So yesterday she came to me, I assessed her. I think she will make a good candidate. This is her MRI scan. Fairly recent, a few months ago. As you can see, some residual disc, more on the left, right, no surgical target. She's seen 2 neurosurgeons independently. No one wants to operate, not because she's a mad patient, but because they don't believe they can help her. So I think she will do well with the stimulation. It will be interesting for me to update you at some point. Sorry? You would have. I'm not a neurosurgeon. Yeah, it's okay. So, is there a role for spinal cord stimulation in the algorithm of low back pain and sciatica in UK? Short answer is yes. It's at the end of algorithm, but once patients go through the mill as Jackie went, they usually come to us. And then we see them. So just a very few words about, so far in the last 9 years, we've implanted 210 patients, mainly with lower extremity pain, with or without back pain. We implanted upper extremity pain with or without neck pain. We've implanted trunk pain and pelvic pain, fewer numbers, but still. All patients had a very thorough multidisciplinary assessment before, once they've been referred. They normally, I show you our pathway. Our pathway is when the referral comes to spinal cord stimulation service, the consultant, one of us, either myself or my colleagues, see them, assess them, collect the information, and we tell them very little about whether they're going to get it or not. We tell them that it'll be spinal cord stimulation, MDT, multidisciplinary meeting, that will decide initial recommendation. And that meeting with 2 neurosurgeons, 2 pain doctors, 2 spinal cord stimulation nurses, pain psychologists, pain physio. So we normally see 10 patients without patient. We don't see them, we actually discuss them in a meeting. And we make a provisional recommendation to go on a pathway or not to go on a pathway. And for those who go on a pathway, they then see pain nurse, spinal cord stimulation nurse, who goes into small details of what patients should expect. That it's not going to cure all of their pain, that it's going to take away just a part of the pain, leg, not necessarily back. How to live with that they have to understand that there is an IPG, they have to recharge it, they have to replace it at some point, and so forth. So that is very big part, including the psychology and physiotherapy functional assessment. And at that stage, it's still irreversible. One of our colleagues might say, actually, I don't think patient is ready, and patients having social issues at home, psychological issues at home. So at that point, we will terminate and will not proceed. And for those who go past that important barrier, we then implant. We used to do 2-stage implantation until 2019. when we would implant the trial stimulation for a week or so, and then we would convert the ones who respond well. However, we then looked at our results and we saw that we convert 96%. So what's the point of trialing and increasing the risk of infection, which I'll talk about in a moment. So since 2019, absolute majority of our patients are implanted as a single stage. We rely on our good selection criteria, and generally I'll show you the results a little later. They're good. And then we get quite frequent return visits of these patients to the reprogramming clinics, which are led by the nurses with some representation from the engineers from the companies. And with some devices, our nurses are absolutely fine to reprogram themselves. With some other devices, they're not so sure, so the company engineers are present. And at the end of year one, the patients will see a consultant, and if everything is more or less okay, they will be discharged with an open referral that can come back at any time for any troubleshooting. So this is our cohort of patients. Median age of 52, female dominant 63%, slightly overweight 31, BMI of 31, baseline pain severity 7.3 on a brief pain inventory, functionally 15 out of 24, yeah, so quite severely affected by function, and low quality of life on EQ5ED. So after 1 year, they improve. Improvements aren't as dramatic as you can expect when you read some nice RCTs, and I'll talk about a few moments later. But there's still improvements across pretty much all the PROMs, all the patient-reported outcome measures. So at 1 week here we have a drop in pain severity and pain interference, improvement in function, and particularly improvement in quality of life. That is quite startling. From 0.25 to 0.6, it's a big improvement in quality of life. So they quite like it. And you know, it's our job to make that last. So what is also good, that morphine consumption goes down quite significantly. So in year one and year two, we see consistent drop in morphine concentrations in patient usage, and across every other medication, you do get quite significant and predictable drop in gabapentin, amitriptyline, pregabalin uses, and all across the range of other opiates. Cost-wise, we've just calculated how much one implant saved money just for the medications. So for one patient in 2 years in our hospital, we're saving £4,253 per patient. Doesn't sound like a lot, but it's only 2 years, and if the trend is decreasing, I think by year 4 normally that's the economical kind of 0 point is reached, and then you can gain from there. So complication rates. So the complications can briefly be divided into 3 parts: infection, hardware migration, or malfunction, and lack of effect. So if you combine them or together and look at the literature, the complication rate is 30 to 40%. Fortunately, majority of these complications are minor and easily rectifiable. Now, since in our hands, when we started doing in 2013, as a double-stage procedure, we would implant, externalize for a week, and then convert to internal IPG, we didn't get quite good results with infection rates. We looked at the antibiotics, we looked at the technique, we looked at the times, laminar flow, you name it. And until we've changed to a single stage, the infection rate was above 10%. Now infection rate is 4.7, which is well within accepted range. I think 5% probably is the ballpark figure for most things spine-related, as far as I'm told by my colleagues. So we're quite happy with that transition, and I think our complication rate is within the well-accepted range across all 3 major complication domains. Now, I probably will go past quite a few slides and go to maybe the most interesting part of my last 5 minutes if I have. Do I have 5 minutes?
Our time is at your disposal, so for you it's to
Thank you. Thank you very much.
well, we are tired of that.
So in terms of what's new in spinal cord stimulation world, this is interesting. This is Saluda Medical. This is a company, I think they're based in Australia. So they came with the first device that can measure evoked compound action potentials in the spine real time during the stimulation. And based on that measurement, there is a closed loop now which automatically adjusts stimulation parameters to keep stimulation at all times within the therapeutic range, which is very interesting. No one's come up with this engineering solution before. So they've published the first randomized controlled trial a couple of years ago. It's funded by companies, so yeah, there may be some bias, and company was quite involved in all parts of the RCT, including the data collection, analysis, and a write-up of the manuscript. However, that's something to keep an eye on, because I believe that we've never been able to have an objective measure of our stimulation. We relied on either paresthesia or patients reported pain relief. Now, there is a possibility to objectivize that and see whether we can improve matters. Based on this first randomized controlled trial, it looks as though a closed-loop system works really well, even better than the other comparators at the moment. But watch the space. And just a couple of pictures in the end, just to show our kind of everyday, mundane failures and successes. This is, 76-year-old man with quite crumbly spine, or osteoporotic fractures before the implantation, kyphoscoliosis, back and bilateral leg pain. So implanted, I think we implanted him sometime in 2016 with a double lead electrode. Initially, he had good response with the leg pain, less so with the back. Expected perhaps. That's his spine. These are the electrodes. I don't know whether you can see them. Still, after 6 years, they're reasonably midline. They stay in the same level despite quite crumbly anatomy. And in the new CT scan, there is a new osteoporotic fracture at L4. So he's got a lot of back pain, new back pain. So he's not what I would call a success. But here you go. Sometimes you win, sometimes you lose. At least he doesn't want it out. So this is interesting. Young Polish gentleman with pelvic and scrotal pain that my colleague did pulse radiofrequency on lower thoracic dorsal root ganglia bilaterally and had 2 months of pain-free. So he thought maybe we should stimulate his dorsal root ganglia with dorsal root ganglion stimulators that are available through Abbott. So we did. He placed 4 DRG stimulating leads at L1 bilaterally and at L2 with no effect essentially. He was, after 1 month it was clear that it was a failure, and 1 year later, patient was annoyed by the IPG, so he wanted it out. And as, I don't know, it's probably not easy to see, but I personally have very skeptical view of DRG stimulators because I only put like 3 or 4. But the amount of, the flimsiness of the electrodes and the amount of loops that you have to do to make sure they not migrate is, in my opinion, not worth our while. So he was explanted. Now another slightly better story is on a very interesting patient. He's a young 40-year-old farmer, local farmer, who donated half of his liver to his cousin and had, an altruistic liver resection, which went really well, but he was left with pain in the right upper quadrant which probably was coming from one of the peripheral nerves because it was very consistent with the drainage area, where the drains were left. And he's gone through the mill, so they really wanted to help them out in London. The procedure was done in London, but he eventually came to our clinic. And long story short, I put, again, he was one of the ones that I thought I'll place DRG stimulation leads into him on the right side, and it worked. He was happy for 1.5 years, and then it stopped suddenly working. And we couldn't, I understand what's wrong, because company was checking the impedances, and impedances were good. X-rays were not showing any lead migration, but it just stopped working. So I didn't like the technique, so I took everything out, and I put the 16 lead Infineon lead at T60, 70, T8 on the right side of midline, and fairly simple procedure, one lead, Boston Scientific this time, and I looked at his, this was done just before Christmas last year, and I looked at his chart yesterday, and he is on no medications at all, and he was on 225 of pregabalin twice a day, and he was on tapentadol 50 twice a day, and amitriptyline. I'm happy, I'm sure he is happy. Talking about happiness. So this is the last last patient that I wanted to share, 49-year-old female, complex regional pain syndrome in one of the legs, implanted elsewhere, not in our service, back in 2011. And effective spinal cord stimulation, leg pain much better, she was happy, and then she moved to our kind of region, and we took her over to her care. So we saw her first maybe end of last year. Nothing special. We gave her a new recharging device because the old one wasn't working well. And she came last spring with this, and we couldn't quite work out what's this. She's been implanted 11 years ago. This is the implant scar, midline scar in the lumbar level, and it was a painless, fluctuating lump she came with. Otherwise systemically well, the lady, no pain, everything's working fine. So we CT'd her, CT scan showed some bulge but no obvious collections, so ruled out the infection, again 11 years later, unlikely, but... So then she came a month or so later, and that was that, and we didn't like it. So I referred her to my colleague, plastic surgeon. So plastic surgeon wanted an ultrasound, so he did an ultrasound, and yeah, there was a sinus from the battery side all the way to the dermis, very highly vascularized, another sinus forming. So at that time it was already oozing and leaking. The patient was systemically well still. So we knew it's bad, it's infection, and we have to take it out. So we took it out in September of this year. So surgical note reads superficial abnormal looking tissue, wound edges, debride, wound swab sent in, nil evidence of deep infection, lots of scar tissue, some serosanguinous fluid around the implant site, nil evidence of infection. So, and CRP was normal, white blood cells were normal at all times, and then, of course, after the operation, a day or so later, the microbiology came, heavy growth with Staph aureus and heavy growth of mixed gram-negative flora, Enterobacter cloacae. So quite resistant to a number of medications. So she was continued on vancomycin and Gent, I think. And this how her post-operative wound looked on day 9. So still systemically well. So she's at home with intravenous antibiotics, has a PICC line in. So the reason I presented this, that 11 years later, infection can happen. So, so in summary, spinal cord stimulation, these days we know it can effectively treat chronic neuropathic pain, improve function, sleep, quality of life. Severe complications are rare but not zero. Data are emerging on it being effective on painful diabetic neuropathy patients. This is quite en vogue these days in the SCS world. Novel technologies such as closed-loop stimulation may revolutionize the field in the future. Time will tell. And multidisciplinary work is the key. Thank you very much for your attention.
Thank you, Dr. Tomaszauskas, but please stay where you are. Maybe our topics are quite different, and that's why maybe it's good to ask questions immediately. And one question came already in the middle of your presentation. Dr. Valainis, the head of neurosurgery of our Strategic Hospital, asked, maybe not directly, but how and when you make the choice to undergo traditional neurosurgery or even orthopedy or stimulation?
Again, very good question. I think I have to be honest. We have a fantastic neurosurgical team working in our hospital, and we have a fantastic relationship with them. From my training years and my recollections, this not always is the case in some hospitals. So we are lucky. So with neurosurgeons, we have a very good understanding. Essentially, we like every patient that comes with a radicular pain, with a disc, we like their opinion, apart from very straightforward cases. And essentially the question is there a surgical target? Our surgeons, at least in our neck of the woods, they have become far more conservative when it comes down to discectomies, fusion operations. They tell me, and I can only quote what they're telling me because I'm not a neurosurgeon. So they tell me that they've learned from their own mistakes in the past, or mistakes of their teachers, who were far more eager to provide surgical services and to take parts of the disc, or to fuse the disc, or to put a titanium cage and screws. So that shift has been essentially influenced by looking at their own results, and they are far more conservative these days. So if they don't see a surgical target, and there are two nuances here. There may be no surgical target that they would be considering a surgical target, or there may be a surgical target but the patient is complex and they don't want to operate. So we have an understanding, and we understand that sometimes they don't think that it will make a long-term success for the patient. But the same rule applies with the spinal cord stimulation. That's why we have these long pathway that leads to an implant. We have ample opportunities to get to know the patient, get to understand are the expectations realistic? That's a very important part. Do they have a plan B? What happens if spinal cord stimulation fails? Have they thought about, do they put all the eggs in one basket? So these types of conversations are very important for both parties to help patients to understand the reality of it. It's not a cure, it's not this magic bullet. For us, it's also important to understand our limitations. Well, again, yesterday in a clinic I had a complaint from a lady who complains that she's been denied spinal cord stimulation. She claims it's because of her obesity, which is not true. I showed you, we put stimulators in BMI of 45, it's not a problem. But we don't believe that her pain would be responsive to this treatment. But it sometimes takes a lot of, it's a process, it's a brain process.
Any other questions? Not at the moment. So thank you very much, Wolfing. We want to ask you such a tremendous, fantastic presentation. I think we should think also about such a practice in our country. Next presenter is Dr. Jānis Mednieks, neurologist, working at one of the biggest hospitals, Paula Stradiņa Clinical Hospital, Clinic Diamond. Also, Dr. Mednieks is on charge of neurological service of healthcare centers. So, please, the floor is yours. for your presentation. And the top topic is repetitive transcranial magnetic stimulation in neurological and psychiatric conditions in outpatient settings.
Yes, I'm just trying to. Yeah. Okay. Thank you for inviting me and to discuss the method that I am using now for about 4 years already in Latvia, that I learned actually in France, and I saw actually it's quite good to use in both neurological conditions as well as for the psychiatric conditions, and I saw actually how it's actually implemented in both fields. The same device actually was used, let's say, in the morning for psychiatric patients and then in the afternoon for neurological patients. And that's where it's good that this device this method is available in a clinical university hospital settings where actually you have both psychiatric services and also neurological services. Well, until the moment in Latvia we have had the chance to run this method and to use it in the outpatient settings, and since this is a non-invasive technique and actually this the usages of it is actually becoming more and more wide, and also it is good for outpatient settings, although I would say that from time to time I feel that maybe some of the conditions in hospitalized patients will also benefit from Rtms. Development of TMS, it's quite it starts from the point that the humanity learns how to generate a magnetic field, and then if you do it with high intensity, actually you can activate certain parts of brain, not very locally, but nevertheless you can have some physiological effects, and that was done already at the end of the 19th century. And then it took about 100 years for the first human to be stimulated for the diagnostic purposes, because we know that TMS nowadays is also used to test, let's say, for example, some neurophysiological aspects and some tests. So, for example, motor evoked potentials is the ones that you test usually in the humans with the TMS. Otherwise, you would use an electrical field that is very painful and it's not suitable. And then what are the principles? How do we get the stimulation? So basically, there is a high voltage current in the coil, and it's about 1,800 volts. And then it is actually generating much lower intensity electrical field. And why do we need magnetic field? Because if we would like to stimulate the brain and to evoke some action potentials intracranially with electrical field, then it should be too intense, and it would be actually painful. So nowadays it's done only intraoperatively and under generalized anesthesia. And so once we have the magnetic field, so we have also we create electrical field already intracranially, because for the magnetic field the skull bone is not a limitation to pass through. And then if we apply, let's say, for example, to the motor areas of the primary motor cortex in the brain, so we can evoke, let's say, the motor evoked potentials, activate the corticospinal tract, and virtually the same effect or similar effect will be if we apply this technique elsewhere on the brain. And so we can actually target it quite well. It depends where we apply the coil, basically. And then everything depends on the way we actually deliver these magnetic discharges. So on a certain extent, we know that from animal models. On the other hand, we know that empirically if we, let's say, stimulate with high frequency, so the stimulation is over with a frequency over 5 Hz, 10, 20 Hz usually, then we sort of stimulate that area of brain. Let's say if we take the motor area, so we get an increase in map amplitude. And then if we do with low frequency, they're usually 1 Hz, so we sort of inhibit. And then there are some other advanced protocols, so it's when you actually stimulate with a higher frequency. That also comes from the animal models, so-called theta burst stimulation. Well, if we look at some of the situations where Rtms is used, so how do actually we explain the effect? So the use of Rtms in pain treatment, which was the first neurological sort of indication, trigeminal neuralgia, post-stroke pain, everything that actually where the spinal cord stimulation does not work is very good for Rtms. So it's the central pain rather than peripheral. So, for example, if we have stimulation for the pain treatment, what do we see on the PET scans afterwards? There is actually increase of the endogenous opioid release, and that is one of the explanations. Well, if you look at the pain matrix, then you see that actually M1 is not there, which is interesting because what you see here is that M1 is the main target treatment for the pain treatment. And how do we actually got there? It was by the surgeons, neurosurgeons rather than from the neurologist. There were some ideas from the Japanese neurosurgeons at the beginning of 1990s. I was actually the team of Tsubokawa. They wanted to stimulate the primary sensory cortex, and they did not have any effect on the pain in trigeminal neuralgia. And then when they inserted the stimulator, it was an epidural stimulator, a bit by chance, a bit more to the frontal. No, it was rostral. It was the rostral, yes. And then actually they got some results, and nowadays, due to that effect, they're inserting and the epidural stimulators only on the motor cortex, and also non-invasively we also stimulate only primary motor cortex. And if the sensory areas are targeted, then only these associative sensory areas, not the primary ones. And then, on contrary, the dorsolateral prefrontal cortex that we use mainly in the depression treatment is actually targeted because we know that in functional studies it is this area that is also with an altered metabolism, so it's decreased on left side and increased on right hemisphere normally. So what do the system of Rtms consist of? And this is the system that we have in our clinic. So of course the minimum what you need is to have a stimulator and then the coil that delivers the magnetic field. But if you want to do better, and especially that's if you target other areas a part of M1, then you would like to actually have the neural navigation, because then you can be far more precise for your stimulation. And the other benefit is that if your patient moves the head during the treatment, also you see that on the computer screen, and you basically can adapt the head position and have the precise target. And then, of course, Rtms is already for a long time available, and the first indication that was approved by FDA was depression in 2008. And what is the level of proof for the use? Actually, if we look at the neurological conditions, and these are the guidelines, European ones, they were released in 2016, and now there's an update in 2020, and we see that neuropathic pain is very good and we see a quite effective treatment. So it's a class level A if we stimulate contralaterally to the pain side with high frequency. There is certain level of proof for fibromyalgia, but you have to realize that fibromyalgia, sometimes it's better to stimulate actually the dorsolateral prefrontal cortex that we stimulate for the treatment of depression rather than for the treatment for the stimulation of M1. It's just to say that in some pain conditions the mood is also very important, and it seems that these frontal mood networks are also involved. And what you see, actually, there's other conditions, neurological conditions, that actually have a certain level of proof of efficacy. But just to say that in neurostimulation, the problem is not actually that it's been proved also in Rtms it's non-effective. It's just to say that there's not enough of trials, there's not enough of patients that where the efficacy has been shown. Okay. And then also, if we look at the psychiatric conditions, yes, there is definitely the proof of efficacy in depression, but there's also some other indications that are considered. Let's say, for example, addiction, and for example, in cocaine abuse, there have been some trials that could be applied. Well, what have we done so far? Let's say in 4 years, we have had 172 patients, and I just looked at 51% was with depression, 5% with OCD, if we look at some psychiatric conditions, and then 23 pain patients. Not that many actually, and then 9 from them with trigeminal neuralgia. And I just looked at the trigeminal neuralgia a little bit more in detail. So out of 9 patients, let's say 7 had at least 50% of pain reduction after 15 to 20 treatment sessions. The problem is actually that the effect is not lasting forever, and it seems that it will be from 1 to 2 months. And actually, those patients that benefit for a long term, they have a follow-up treatment, let's say 1 monthly treatment session. How do we do actually our treatment and carry out? So we have a screening for the patients. Let's say we have either me as a neurologist, or we have another psychiatrist who's working in this to see if these patients are suitable, if the pharmacological treatment is actually tried out and it's been appropriate. Then we do head MRI T1 neuronavigation, so thin layer sequence for the head model. Then we do the head model, and then we have a first stimulation session with a doctor who is a coordinator and who is also carrying out the stimulation. And then the patient is having treatment sessions daily for 3 to 4 weeks, and then the assessment of results, and then we see that in part of patients we will have follow-up treatment. And then one case with some post-traumatic headaches due to motor vehicle accident. Was a lady she was depressed, but also having like dull pressing headaches that did not respond quite well to the treatment. You can see she had gabapentin in high doses, amitriptyline as well, and venlafaxine, and it did not work actually. We didn't want to go for the opiates, so Rtms was suggested. We tried M1 for the treatment of pain, but actually that does not responded well after some 10 sessions where you already normally see some benefit. And so we tried out the dorsolateral prefrontal cortex, and it worked out quite better. So actually, just to remind that mood is also important in some pain conditions. Thank you for your attention.
Thank you, Dr. Medniks. Questions? Not at the moment. So thanks a lot for such introduction of such a method in our clinical practice, and this wonderful presentation. Our last presentation is about introduction of VNS method in Latvia. VNS is an abbreviation of nervus vagus stimulation. Material, of course, is not big number of cases, maybe do not allow us to make some big conclusions. But at the same time, it shows the way how this method was introduced. Quite difficult path. And maybe it could be useful, for our clinicians to believe that if we work hard together as a team, we can succeed. Author of this presentation is Dr. Jurgis Trautmanis. He is a neurologist, epileptologist, also chairperson of Latvian anti-epilepsy society working in the Children's Clinical Hospital of Latvia here in Riga, and actually enthusiast and introducer in this hospital, and I think in all Latvia, of this method of nervus vagus stimulation. My role as a retired neurosurgeon, I am now has a certificate of organizer of healthcare to take care about the social economic aspects of this method because everything costs money, and that's why we together made such a big work, learning all preconditions, all possible literature, and together prepared a publication which was published in our medical newspaper, Latvian Physician, some time ago, allowing also all our medical society to learn about this method. First, we started available publications all over the world. One note, we have seen that there were some more than 1,000, and 500 of them mentioned effectiveness, security of the method 150, simplicity, it was not quite simple, more than 30, costs, you see the lowest number is for cost, so that means method is not so costly. Mechanism of action and review of articles. And conclusions after analysis of all the available for us literature that vagal nerve situation is safe and effective alternative for adults and children with epilepsy, refractory for medical and surgical treatment. So when drugs were not possible to cease or improve the clinical neurological status of the patients, then nervus vagus stimulation is one of the choices. And by the way, I can also join that what was stated by Dr. Tomashauskas, that here we also see economical effect. I will talk a little bit later how we achieved it, this introduction, but it was a great argument for our National Health Service that we have economical effect. So drugs are replaced by this method, of course, in the case if the method is successful. But what's about success? Available literature showed that quite in plenty of cases, here you see 40%, 67%, showed 50% reduction of the events of epilepsy or of seizures. That means quite promising, method for us while we introduce. That's why, taking into account also available literature, we found that 48.46% of cases, the intensity of seizures decreases by 50%. It's in medicine, in healthcare, quite a good result. Technically, how does it look? Of course, in the Clinical Children's Hospital of Latvia in Riga, a team works to achieve some effects of this method and implant necessary parts. As you see, main parts are demipulse generator, which is implanted beneath the skin, then thin flexible lead cords leading to the location of nervus vagus, and electrodes, as you see, placed on nervus vagus. Of course, this is a job of neurosurgeon, and Dr. Strautmanis, who is neurologist, is working in a team with neurosurgery service of our clinical children's hospital, and of course technicians. We studied also the costs before introducing the method, because National Health Services service who distributes money and supplies for financial supplies for our clinics. So you see, devices are not astronomically costly. We can even say quite cheap. These are a little bit above 2,000 euros in majority of the countries. What is about potential number suitable for VNS therapy in Latvia? This was another important question. Of course, we started Lithuanian experience of other countries. So how many such procedures necessary? And at that time, while counting and taking into account experience other countries, we understood that the maximum number of patients suitable for VNS therapy could be 30 per year, 15 children and 15 adults per year. These are the dates of Dr. Strautmanis, and these were the numbers, we promoted and we sent to our National Health Service with maximal expenses of 721,000, taking into account all surgery devices and all other services, checks and whatever. At that time of publication, Latvian experience in VNS therapy included 7 children, all implanted in Riga, in Children's Hospital. That's under the supervision of Dr. Strautmanis, and 2 adult patients, both implanted abroad. All patients have demonstrated at that moment significant progress in reducing the number of seizures, as well as improving the health and quality of life. Of course, these are preliminary conclusions. Number is not impressive. But, of course, it encourages us, go further. And after discussions, presentations, publications, we all together, neurologists, neurosurgeons, industry, National Health Service, for the year 2022, for the first time, the healthcare budget provides means for VNS devices. And first state-covered VNS device implantation planned for October 2022. Actually, it was planned for this week, but physician strike changed a little bit the timetable. Colleagues at the Children's Hospital were afraid that something can go wrong. I don't know, but this is what information I do have, but it's really, great success. Of course, just the beginning, but the door is open, and good results, I think, will encourage our National Health Service to donate more in the budget for neurostimulation, not only for VNS, but all neurostimulation part, because political goal from Ministry of Healthcare, as much as I understand, not to send our patients for neuromodulation procedures outside, but to try to do it here as much as we have, due to, of course, costs which are lower here, and of course simplicity for the patients to reach this way of assistance. So, preliminary conclusions. VNS therapy in Latvia was not included, and as a result, of course, most patients were not available to afford this way of treatment because it's costly. This treatment method is worth of state compensation. We have achieved, because studies of many authors and practice shows significant therapeutic and quality of life improvement effect, which certainly also has economical significance. And after all, opening of state funding was achieved through joint efforts of neurologists, civil servants, and of National Health Service, and of course patients, patient societies, patient organizations. So thank you very much. That's such short introduction. Maybe it's more political how to achieve the goal, but of course it's based on good clinical practice of our clinical children's hospital. So now please for the questions.
Yeah, I have a question for you, and it's also for regarding the spinal cord stimulation. I think, of course, you said about the drugs in the spinal cord stimulation and then also in the epilepsy, but I think you cannot really just judge the cost effectiveness if you just look at direct medical costs. I mean, and this is the main problem, at least in Latvia, because you can easily show what are the direct medical costs, but you cannot show really what is the indirect cost. So not earn money for the budget because the patient is not, let's say, not working. Also, the loss of quality of life, or some years lived with a poor quality of life. I think this is the point. If our National Health Service and the Ministry of Health would take this into account, I think that would also implicate that we have to use and we have to get the fundings for the neuromodulation devices a lot more intensively than we actually now are having. And this is also interesting when you look at the data from UK, what is actually, how do you count how much costs or how much the government of UK is ready to spend for 1 year of life with quality?
Well, that's an excellent question. So essentially, healthcare economics and cost utility analysis is a very important part of any decision that public health service takes in the UK. So for that, many years ago, there is that big institution created called NICE, National Institute of Clinical Excellence. So the job of NICE is to assess and either recommend or not recommend any new treatment. So, and of course, that is based on mainly their health technology assessment. The big part is cost effectiveness analysis. Now, in order for, you have to know how much is your society willing to spend to gain an extra quality life year. And that is dependent on the society. In Australia, there will be different numbers than in UK. In Latvia, it may be different numbers in UK. So I remember when I was preparing this similar talk for Lithuanian audience a couple of years ago, I looked into the numbers. So I mentioned this magic number of £20,000 in UK as a threshold above which it becomes not effective a treatment. And it's not an absolute number, it's a ratio. So in Lithuania at the time, the similar number for Lithuanian Ministry of Health was somewhere, I can't remember, was it 6 or was it 9,000? So it was significantly lower, but that's what Lithuanian society was willing to pay for a quality or life year gained. So, and I think, I believe, if you look into the health economics, and I'm sure industry that deal in this business, they have these numbers. You have to know what the Latvian threshold is, and also countries differ. Sometimes in the UK, this number is made public, so everybody knows. So it's good and bad. And in Australia, it's implied. Everybody thinks they know what is the threshold, but actually government doesn't say. So that's so once you know the threshold, then the next big step is to show that your treatment is well below that threshold. And I, as a simple doctor, I only think my only advice to people who do research is whatever research you do, please include quality of life assessment, because that goes into the formula.
Yeah.
So if the more research we have with an improvement of quality of life, the more likely the health technology assessment will show that actually is a positive step. So that's my comment.
Thanks a lot. I think really, but you see, when you continue and have to maintain this budget every year, yeah, to continue with patients, to continue with research. But when you are beginning and introducing something, it's different. But what we understood, that National Health Service of Latvia, they always look for this economical effect. How can we prove if we haven't done it yet? You know, we do not have this bulk of material. We try to find some arguments in literature wherever, speaking frankly, even then this economical effect is not so clear, but this is clear demand, and those ladies working in National Health Service, they check this literature resources, you know, if really we do have some economical effect. But of course in this case it's too early to speak about health economy.
My only comment to that would be that you don't need to reinvent the wheel in Latvia by doing your own new health economic assessment for these treatments. You know, the question is not, we know how much they say. The question is Latvian society or health fund is willing to pay that cost? And that is a completely different question, I think. So essentially, when the time comes to submit papers for a new treatment, you know, there is absolutely fine to utilize other countries', you know, costings. The question is that matching your threshold for ability to pay? You know, so that's that. And for instance, for spinal cord stimulation, based on what I know about how much quality of life years you can gain for what price, Lithuanian health fund should in theory, I don't know the inner workings obviously, but based purely on the numbers, they should be able to match it.
You wanted to add something?
Yeah, but I agree with this. Just actually, this is also the problem, because I think there is some of the areas in medicine which are are where either the patient organization or the medical sub-societies, they're pushing towards the introductions of the treatment, because this is innovative. I mean, and sometimes it works for them, because they say this is used elsewhere in the world. We also have to use, but then also I think we have to be sort of able to, at least for some part of patients, introduce some novel technologies, so that we are familiar with the field, and also that in general we improve the quality of life in the cheapest way we can, actually. Yeah.
I would also add that what in UK we have one threshold for non-cancer treatments, and because of the very strong patient movement, there is another treatment threshold which is much higher for cancer-related treatments. As you know, in oncology there are lots of new medications, lots of new expensive treatments introduced every now and then. So, and they have that other threshold. So the society has decided that fine, for everything else we have this, but for cancer we make an exception, and we fund it in a I think it's 50,000 rather than 20 to 30,000. And then there is another threshold for rare diseases, you know, the orphan diseases that no one invests into.
Yeah, this is true. But I think in the Latvian society, if you ask them what do you want, if you want to have a society that is healthier, that is a better quality of life, or you want to treat something with novel technologies, I'd say they will actually, if asked in that way, they would say we want to get better results on a higher number of persons. And I think this is something that is not actually mentioned in these discussions.
Okay, thank you. Any other questions or ideas to be expressed now here? Not at the moment. So our seminar was recorded, and it will be sent to Latvian Society of Neurologists, Latvian Children's Society of Neurologists, Latvian Anti-Epilepsy Society, Latvian Society of Neurosurgeons, and the Latvian Pain Research Society, Ministry of Healthcare and National Health Service, serving, you know, as a source of information and of course of encouragement to introduce this neuromodulation methods. We have had 4 presentations, very different. It was brain, it was a spinal cord, it was a brain concerning Parkinson disease and psychiatric problems. So I think all this information will be available to our clinicians, specialists. This was our aim of this seminar, and with these words, if we do not have any more questions or wishes to express some ideas, with great thanks to our presenters from many countries where we are only 4. It was really great. Presentations were perfectly worked and clear. This will be possible, we know, to learn also later in these records on the Facebook platforms of these societies. So, thank you for everyone, thank you for presenters, for those who were present, for those who followed on the Zoom platform. That's all what we wanted this afternoon to say. So, thanks a lot. Goodbye.
Thank you.